Sound check. 1, 2, 3. 1, 2, 3.
Are we streaming? Are we streaming? Are we? Yeah, okay. Hi, good morning, everybody. Good morning, everybody. Okay, so good morning. Welcome again to the Interdisciplinary Cerebrovascular Symposium. This is the second day of the meeting, and we're gonna be talking a lot about aneurysm wall enhancement. This is the topic for this morning. We're gonna start with Ashrita Raghuram. She's an undergrad biomedical engineering. She's a future medical student and is a superstar working with us in our lab, looking at aneurysm analysis in determining wall enhancement and volumetric analysis of aneurysms. So we're gonna start with her talk. We're gonna follow the same format as yesterday, where the three presenters are gonna talk, and at the end we're gonna have a discussion. So if you have any questions, please go ahead and place your questions in the YouTube channel, or when we open the discussion, you can also send us questions. So let me just share my screen because share my screen because share my screen.
Hi, my name is Ashrita Raghuram, and I will be talking about our volumetric analysis as part of Dr. Samanego's lab. The goal of this study is to characterize aneurysm growth using modality will be MR angiogram, MRA, and we'll recreate or reconstruct the aneurysm in 3D using a semi-automatic segmentation tool, the vascular modeling toolkit, at two different time points. So we'll do a reconstruction at baseline and follow-up imaging time points, and then co-register those two reconstructions to get a better visualization of changes in aneurysm morphology over this follow-up period. We can also measure the aneurysm volume and use volume change over that period as an indicator for growth. We want to compare this to using 2D measurement, or the clinically acceptable 2D measurement, as an indicator for change in aneurysm size. So the study population that we have are patients who are diagnosed with unruptured intracranial aneurysms. They're prospectively chosen to undergo high resolution vessel wall imaging protocol, and they're prospectively chosen for this study if they are untreated and they have baseline and follow-up imaging data, and their aneurysm is greater than 3 millimeters in size. The mean follow-up time is about 9.5 months. We have 12 patients and 15 total aneurysms, and we're analyzing both saccular and fusiform aneurysms using MRA and T1 post images. So the morphological indices that have been established measure the aneurysm sac and different parts of the aneurysm shape using linear measurements, and also indices that rely on crude volume estimations of the aneurysm sac itself. Our goal is to use this reconstruction method to measure total aneurysm volume or volume change as a predictor, as a better predictor for aneurysm size and changes in global aneurysm size itself. So we're predicting that our growth comes from small dimensional changes in these morphological indices that create a larger change in aneurysm volume. We also want to generalize this method to fusiform aneurysms that don't have as well of established of a method for measurement and identifying growth. Aneurysm wall enhancement has also been shown to be correlated to aneurysm growth. On the left, you can see this study, this follow-up study by El Jadi with 1 year and 18-month follow-up images where you can see aneurysm wall enhancement and changes in the aneurysm size on the left from the time of flight. And on the right, you can see a figure from a study by Wrinkle showing that enhancement at baseline on the T1 post, panel B, can be shown to be correlated to aneurysm growth. So you can see panel C and D time of flight images with a follow-up time at baseline and follow-up with a follow-up time of about 1 year. So our goal is to use the 2D measurement or to analyze the efficacy of this 2D measurement, clinically accepted gold standard to recognize aneurysm growth. And something we've noticed is that there's not great sensitivity in this measurement tool, because there's a lot of variability and a lot of subjective choices that need to be made when picking the best dimensions to measure. So we had 2 novice raters measure the same aneurysm. So you can see on the left and right, it's the same ICA aneurysm, and they measured the same dimensions from the same slice of the same aneurysm, and got different measurements based on the placement of their markers, based on their windowing choices, based on the angle of their mark line. And we saw that there was a lot of variability based on some of the choices you can make while you're measuring the aneurysm size. We also compared, after comparing inter-rater reliability, we also compared this to a clinical adjudicator who's an experienced neurointerventionalist who measured the same dimensions on the same slices. So our aneurysm reconstruction methodology starts with reconstructing the baseline and follow-up aneurysm and parent vessel using the vascular modeling toolkit, or VMTK. So VMTK allows you to place seeds and grow your segmentation from those seeds based on threshold settings. So it gives you some control over your segmentation in a quantitative manner, along with giving control over smoothing parameters and other parameters for reconstruction itself. So we created a reconstruction at baseline and follow-up, and then we registered those 2 reconstructions using the built-in registration method that uses iterative closest point registration algorithms to register the baseline and follow-up segmentations to each other. The reason we included so much parent vessel in these segmentations was to improve the accuracy of the registration, such that there were clear landmarks to match up from the baseline and follow-up data, even if the aneurysm body changed drastically in size or shape. After we registered the 2 baseline and follow-up reconstructions, we went about isolating the aneurysm. Traditionally, you would see saccular aneurysms isolated by creating a plane at the neck of the aneurysm. However, we decided to create planes perpendicular to the parent vessel to generalize this method to both saccular and fusiform aneurysms, so we can accurately apply this protocol by creating clipping planes as close to the neck as possible in the saccular aneurysms and as close to the last dilation as possible in the fusiform vessel itself. So you'll see other reconstructions that have longer, more perpendicular cuts. This was as close as possible to the neck without cutting into the aneurysm body itself. And this is a left ICA aneurysm we're looking at right now. So once we've clipped the baseline reconstruction, we can overlay the follow-up reconstruction and see in red the clipped baseline reconstruction and still see our clipping planes, so that we create new clipping planes on the follow-up reconstruction and effectively slice at the same areas on the follow-up images. So we can be sure that we're using the same anatomy to analyze the aneurysm volume itself. So there's the overlaid reconstructions with the baseline in red and the follow-up in white. You can see that changes in the aneurysm shape itself are still detected here because we clipped the aneurysm parent vessel and not the aneurysm neck. And there's another orientation of the same aneurysm itself. So here you can see we've overlaid, now we've changed the color scheme so you can better see how the follow-up images overlay onto the baseline images. The follow-up reconstruction is in red and the baseline reconstruction is in white. And you can see kind of areas of growth. You can see a bleb where that arrow is pointing. You can see changes in the aneurysm dome itself, and maybe an increase in aneurysm size. And our volume itself, our volume analysis found a 13% increase in volume from baseline to follow-up reconstruction. And the 2D measurement that we used from our experienced neurointerventionalist found a change in neck size of about 1.1 millimeters. So looking at this 2D measurement system for fusiform aneurysms, this is a fusiform basilar trunk aneurysm that has these are the 3 different planes of that one aneurysm, looking for the largest diameter for the aneurysm. And our experienced measure found that the largest diameter was about 11.2 millimeters. And you can see our novice raters struggled to agree or found slightly different calculations based on the angle of their placement of their markers. So you can see that defining the largest diameter is really subjective, especially in a fusiform aneurysm, which will have lots of changes in shape and diameter. And we want to better characterize how even the smaller changes in diameter can contribute to the overall aneurysm size and changes their aneurysm growth. So here is that same aneurysm reconstructed in 3D. Again, you can see the follow-up image the follow-up reconstruction is in red, the baseline reconstruction is in white, and you don't see as much of a change in the morphology or a huge amount of growth. We found about a 5% amount of growth based on 5% increase in volume based on the baseline and follow-up data. And the diameter change that was detected was about 0.2 millimeters. So for these large aneurysms, finding the right diameter to detect the right change is part of the trick of the 2D measurement, whereas the 3D measurement will detect all of the diameter changes in one calculation. And that's why we're advocating for the 3D, the volume method for measurement. So you can see here on the left-hand side, we have a left ICA supraclinoid aneurysm, and on the right-hand side, we have a right ICA paraclinoid aneurysm. On the left, you can see that this aneurysm has grown significantly, about 62% change in volume. Again, this is a very thrombosed aneurysm, so the MRA is not able to pick up a lot of that thrombosis. So a lot of this reconstruction is based on only the patent lumen, but you can still see a large amount of growth. On the right, you have a small amount of growth where you can still detect changes in, you can see that there's maybe a change in the orientation of the aneurysm, which may be due to changes in the registration itself, but that doesn't greatly affect the change in volume. We only get a 1% change in 1% increase in volume for this aneurysm. So it's not sensitive to those changes in location due to misregistration of the registration algorithm. So here is a left pica reconstruction. So the pica itself is so small, the 2D measurement could barely detect the change. We got about a negative 0.6, so we got a decrease in diameter of this aneurysm. And you can see in the images how the aneurysm really changed between baseline and follow-up scans. And the diameter might not be the best indicator for the change in aneurysm size. And our volume measurement was detected about a 15% change in volume, whereas the diameter change did not detect that change in volume. So maybe there's a different index that would better detect the changes in the aneurysm shape from that 2D measurement, but our volume analysis was able to detect that even in such a small aneurysm. So we also looked at aneurysm wall enhancement and how that compares to the aneurysm volume. So on the left, you can see our methodology for choosing a region of interest around the aneurysm wall. This goes back to that left ICA supraclinoid aneurysm here. So that's our aneurysm. So we've drawn an ROI around the aneurysm wall, and from that we can grab the max and mean intensity values and normalize those values to the pituitary stalk to quantify the enhancement in the aneurysm wall. So we have two calculations, one for CR stalk max and one for CR stalk mean, or our contrast ratio normalized to the pituitary stalk. So we described enhancement as a cutoff, or anything that has a CR stalk of over 0.64. So our CR stalk max, if it's over 0.64, is enhancing, or if it's our mean over 0.64, it's enhancing. So we decided that we would characterize change in enhancement rather than looking at the percentage change in CR stalk. We looked at a binary measure for enhancement. So we said if it went from enhancing at baseline to non-enhancing at follow-up, it decreased in enhancement. Or if it went from non-enhancing at baseline to enhancing at follow-up, it increased in enhancement. And you can see how that correlates to the change in volume in that table on the left. We weren't able to derive a statistically significant relationship between those two measures, even between the mean change in enhancement and percent change in volume. That might be due to our low sample size. The larger studies might have more success in detecting those relationships. So in the future, we'd like to analyze how aneurysm hemodynamics can combine with morphology to predict the aneurysm stability, to create an index for aneurysm stability that takes into account things like the wall shear stress or the OSI for the aneurysm, and combine that into a score calculated by another study conducted by Meng. So we are hoping to continue our CFD analysis for all of our aneurysms. This is just one of the aneurysms in our study that actually didn't have growth between baseline and follow-up imaging. So we want to investigate how the hemodynamics can affect that growth or affect regions of growth in the imaging itself. And we'd like to acknowledge our contributors and collaborators for all their help in this project. Thank you.
Thank you, Ashita. It was a great presentation. Thank you, Ashita. It was all right. Now we're gonna go ahead with the second talk. Is from Dr. Wise Khan. He did his PhD with David Steinman, the University of Toronto, and was doing further training at Stanford University. And he told us he just is going back to Toronto and joining as a faculty. What was the University of Wise?
It's Ryerson.
Ryerson.
Yeah.
So he's gonna talk us about his research in aneurysm wall enhancement. Please go ahead, Wise.
Let me just pick my screen. Let's see. Share. Okay. Can everybody see my screen?
Yes.
All right. Okay, thank you very much for the nice introduction. So as Edgar said, so I've been working on aneurysm for quite some time during my PhD. So this project or this work was actually during my postdoc, although my postdoc is now focused on cardiac modeling at Stanford, but This was an independent collaboration that I initiated with a neurosurgical colleague, Athanasios Petritis, at Düsseldorf Hospital in Germany. So the goal was to basically understand the association between aneurysms and wall enhancement broadly, right? So I'll just go through some of the motivations, right? So what do we know about aneurysm wall enhancement? So most of you probably already know this, but I'm just going to list out what we already know from the literature, right? So aneurysm wall enhancement is able to distinguish ruptured aneurysms when we have multiple ruptured aneurysms in a patient. We're able to predict unstable aneurysms using this wall enhancement. And these unstable aneurysms are basically the ones that grow and show morphological changes over time. So we know that these morphological parameters are comparable to the conventional parameters of rupture, right? So such as larger size, higher aspect ratio, size ratio, and bottleneck factor, all of which have been proposed for basically characterizing ruptured versus unruptured aneurysms. So wall enhancements correlate with these morphological parameters. We also know that from the study from Naomi Larson that these aneurysm wall enhancement correlates with wall inflammation when we perform histology of these patients after clipping surgery. And lastly, this study from Xiao in AGNR that shows that regions that showed wall enhancements have lower wall shear stresses compared to the regions that showed no wall enhancement. So this is what we know from the literature, and I know there are lots of other studies that have been published, but I don't have time to go through all of them. But I've just listed the main points, right? So what's the addition that we are trying to bring in? So the first thing I noticed was that there are very few methods or robust methods to actually quantify this wall enhancement. And secondly, once we have quantified this wall enhancement, can we correlate this enhancement matrix, whatever that matrix may be, with hemodynamic parameters and be able to distinguish enhanced versus non-enhanced aneurysms? So let's start with the clinical data set, right? So the clinical data set I got from my collaborator in Germany. So we had about 22 patients with 25 unruptured aneurysms. And these were, all of these received 3D rotational angiography as well as vessel wall MRI. Using these aneurysms, or specifically the 3D rotational angiography, we performed high-resolution CFD simulations with about 4 million elements, depending on the extent and size of the aneurysm, with 10,000 time steps. And the CFD method has been verified and validated to capture both laminar and transitional flows and broadly cardiovascular flows. And lastly, we performed post-processing. So we quantified morphological parameters as well as hemodynamic parameters. So for morphological, we computed size, aspect ratio, bottleneck factor. And for hemodynamic parameters, we computed wall shear stresses. So normalized wall shear stresses, which is basically normalized to the parent artery wall shear stress. Spectral power index, which is a recent metric that we worked on, or I worked on with David when I was a PhD student, and oscillatory shear index. Now, so let's talk about the quantification method. So how did we quantify wall enhancement? So basically, what we did was we first registered the CFD model that was derived from 3D rotational angiography to vessel wall MRI using manual landmarks. And the issue here was that the data set I had was very, very coarse. So it's very difficult to actually use an fully automated method to register these two models. So first I assigned manual landmarks at bifurcation sites, and then I just used an iterative closest point method to merge or to bring those landmarks together. So here you can see the vessel wall MRI slice laid on top of the CFD model. And in the second step, we had to segment out the lumen of the vessel wall MRI. So So the issue here was, as I said, it's very difficult to distinguish between what the lumen is when we have, especially in the post contrast or post gadolinium images. So for this paper, or at least for this data set, I computed normal vectors oriented in the normal direction of the aneurysms, extended about 1 millimeter out. And then I computed the MRI signal intensity in all of those, like along all of those lines, and averaged them together to then project it back onto the CFD model. And then I also did some normalization of the MRI signal intensity, because that can vary depending on the method you're using and the scanner you have. So for this, I normalized it based on the volume stack, but there are other methods to do it, such as using pituitary gland or the intensity in that region. So this was broadly the framework we use for quantification of wall enhancement. And then here are some of the results after we performed the CFD simulation. So I've grouped them into the enhanced group and the non-enhanced group, and I've ranked them going from lowest wall shear stresses to highest wall shear stresses. So for example, this patient 4 with ACOM aneurysm had the lowest shear stress, and this ACOM P1 patient had the highest shear stress in the wall enhanced group. So as you can see, some of these showed, focal enhancement, some of these shows partial enhancement, and some of these showed, very high intensity enhancements. And these are the non-enhanced aneurysms. So as you can right away see that the aneurysms that had enhancement were larger in size, which is already known from previous literature, whereas the aneurysms that had no enhancement were smaller in size. Obviously, because larger aneurysms tend to have lower wall shear stresses, which is what we already see from this diagram as well. So these are the key findings from this diagram, that enhanced group had large aneurysms that were larger in size, had lower wall shear stresses. But another thing I noticed was aneurysms that had blebs had high intensity enhancement, which was interesting for me. I'll talk a little bit about that further. So the only metric that showed or that we're able to distinguish between enhanced and non-enhanced groups were wall shear stresses, normalized wall shear stress, and obviously mean velocity, because that's correlated with wall shear stress. And from the morphological analysis, only size and size ratio showed significant differences. So now let's move on to the quantification piece, right? So here we're just looking at differences in non-enhanced and enhanced group. But if we just focus on the enhanced group, right? How do they correlate? Like how do they correlate with the MRI signal intensity that we quantified earlier, right? So in the top row, I'm showing normalized wall shear stresses, normalized to the parent artery. And in the bottom row, I'm showing the MRI signal intensity factor that we quantified earlier. And what we noticed was that the regions that had the lowest wall shear stresses from the CFD analysis were the regions that showed maximum MRI signal intensity, right? So this is the region of lowest wall shear stresses, and here you see high enhancement. This is the bleb region that showed lowest wall shear stress. And then again, you have very high enhancement in this region, and so on and so forth for all of these 9 patients. Now, what I did was I then quantified SAC average MRI signal intensity and compared them to wall shear stresses, both normalized and non-normalized, and I could see the inverse correlation. So it was weak when I used non-dimensional or dimensionalized units, but when we non-dimensionalize it, we can see that this correlation increases. It's not very strong, but at least we see that there's a strong trend that shows that MRI signal intensity correlates with normalized wall shear stress, or inversely correlates with wall shear stress. So at the end, I've put this slide to criticize my own work. So I'm just gonna put this out because there have been studies that have said that some of these sequences, MRI sequences, can overpredict wall enhancement, right? So we know that conventional space sequence can overpredict wall enhancements compared to the more robust motion sensitized driven equilibrium sequence. And this was published by Kulsum in AGNR, who compared about 30 aneurysms. And from space sequence, we were able to only pick up 10 aneurysms that showed wall enhancement out of 30. Whereas when we used the MSDE sequence, there were only 2 aneurysms that showed wall enhancements out of 30. So it seems like to me that this wall enhancement is highly dependent on the sequence we are using, and this may be because of the flow artifacts, right? So the slow flow artifact that can mimic this wall enhancement. So in my own study, I saw that about 9 out of 25 aneurysms that we looked at had wall enhancement, and 3 of them had blebs, and all of them showed very high intensity circumflexion enhancement. So could it be that these bleb regions are actually have very slow flow that can mimic what we see as enhancement? And this needs to be further investigated so that we can better distinguish between aneurysm regions or aneurysm walls that are really truly enhanced versus those that are just showing pseudo enhancement because of the slow moving flow. So in conclusion, I think I have just 2 remarks, right? The first one is we need to develop more objective and reproducible methods to quantify aneurysm wall enhancement. And this can only come when we can develop standardized methods to register CFT with vessel wall MRI. If we can develop automated methods of segmenting aneurysm walls from vessel wall MRI images, and maybe further investigate the ideal method for normalizations. And I know pituitary gland has been proposed by the previous researchers, but some people have used parent artery to normalize, and I think this needs to be further investigated in a larger data set on which normalization method can better predict aneurysm remodeling in the future. Second thing I want to highlight is wall shear stress seems to be a surrogate of wall enhancement, at least from my study and study from the others. But what is the underlying mechanism that's causing this enhancement, right? What is the underlying mechanism? Is it that the contrast, these walls have become degenerated and are more permeable to take up this contrast, or is it some other mechanism? And the study from Naomi Larson was very interesting because she actually correlated those regions of wall enhancement from histology with the imaging. And yep, that's about it. Thank you very much.
Okay, thank you, Wise. I hope you can hear me. Yes, my name is Gabor Janika, and I have the opportunity to chair this session today morning, aneurysm wall enhancement. We have one more talk, a third talk in this session, and after that we have the opportunity to go with question and discussion. So I would ask Wise to stop the sharing.
Okay. Yeah, I can.
And let me introduce our next speaker. Sylvia is also from Germany, from Magdeburg. It's me. And we are working for a very long time together. And she was new to the ICS community 2 years ago. And it was very interesting because she has a bit different background as usual in the ICS community. We had a couple of medical doctors and we had always CFD engineers, but she has a background in computational science, especially for visualization. And I think this is a very nice complementary topic for our community to enhance the discussion. And we go further with investigation of flow condition and the wall, impact on the wall. And I would ask you, Sylvia, please tell us about your recent results. The floor is yours.
Thank you, Gabor. Good morning, everybody. Yes, as Gabor already told you, I'm a computer scientist, and together with my colleagues, we analyzed also the focal enhancement in intracranial aneurysms, and I want to present to you our results. So I will keep the motivation really short. You are all familiar with the intracranial aneurysms, which are depicted on the right side. And the big question is, what will happen if we have this aneurysm? Will it grow? Will it even rupture? And especially for the incidental unruptured cerebral aneurysms, we do not know whether to treat them or not. And as it was also told us yesterday, like the PROTECT-U trial, which was presented by Mr. Vergoven, or in the talks in this session, we want to analyze this topic in more detail, and the enhancement on MR vessel wall imaging might be a well-suited biomarker to analyze this phenomena in more detail. But in our work, we are also focusing on the focal wall enhancement. So what we did was that we, together with the medical cooperation partners, that we examined 21 patients which had 22 unruptured aneurysms at the middle cerebral artery. And we acquired like the 3D MR vessel wall imaging, as well as a 3D subtraction sequence. And the nice thing is that from the 3D DSA, we could extract a 3D model where we will also apply CFD and so on. But from the MRI, we can examine if there was a wall enhancement. And as you can see it here, we did not analyze whether there is or not enhancement, but we also carry out the segmentation of these little regions. So there is a region here at the top, and there is another region. And we used both medical experts. If there was a disagreement between them, then they talked together, and the disagreement was solved by consensus. And what we get from this was that we had segmentations of the wall enhancement. And we used then an image processing tool like MevisLab, and I created a little in-house solution where we could could interpolate missing slices in between. And based from these slices, I could create like a 3D object, and this 3D object was then converted to an STL file. And for the segmentation, we applied a live wire segmentation algorithm. So this algorithm was usually developed for the segmentation of the liver. And so it's like a semi-automatically approach. And next, we want to somehow combine these methods. It was a really nice talk from Mr. Khan right before me. And so you are all familiar with the problem. We have the MR vessel wall imaging, and we have these enhancement patches, which are illustrated here in this bluish color. And we have our nice 3D model from the aneurysm and its parent artery from our 3D DSA data, and now we want to align them. It's not easy, but we choose a really interesting approach. So again, we exploit image processing, and we just carried out a rigid multi-resolution registration from the MRI imaging and the 3D DSA dataset. So what we will get like a function that defines the mapping from the 3D DSA data to the 3D MRI data. And I'm not so much interested in the image data, I'm just interested in this function, which I can save like as a transformation matrix. And now I can just apply this transformation matrix to the 3D volume of the segmented aneurysm. And what I get is like an automatically co-alignment of our previously segmented wall enhancement patches, which are illustrated here in blue. And I can combine them now with my 3D model from the 3D DSA dataset. And so we repeated this approach for all of the patient datasets. And so we co-aligned all of the 22 aneurysms. Now we want to have a closer look what happens with these patches, what happens in the areas where a wall enhancement was visible in the MRI dataset. Therefore, we extract, like all the other guys here, of course, the morphological parameters. For this solution, we also used in-house program I created 2 years ago. It's based on MATLAB, where the user can semi-automatically define a neck curve. This is illustrated here in orange. And then the aneurysm is separated from the parent vessel. And now I have this 3D model of the aneurysm, and I can just automatically carry out all the morphological parameters like volume of the interest or maximum diameter or maximum height. I mean, it's just like a 3D triangular mesh. And then this is pretty easy. And of course, we also extracted like the shape, like the ellipticity index or the non-sphericity index and the undulation index, because as you all are aware that we expected that there would be like a correlation between the flappiness or floppiness of the aneurysm and the enhancement. Next to the morphological parameters, we also were interested in the hemodynamic parameters, and this was, so therefore Philipp Berg, who's also a postdoc at Magdeburg, who's in Gabor Janiga's group, who's our CFD expert, carried out the CFD simulation based on the 3D DSA models, and he used star CCM and the parameters that I listed here. So we also assumed the flow splitting provided by Schnaffer et al. And we used a time-dependent inflow waveform based on measurements in a healthy volunteer, and the blood was treated as an incompressible and Newtonian fluid. And you can see here some illustrations of the hemodynamic parameters, but we did something special here. So we also used our wall enhancement patch, and I will explain this to you in more detail on the next slide. So again, just have a look at our illustration. We have the segmented 3D model from the 3D DSA dataset. So that's our high quality aneurysm segmentation with the parent vessel. And we also have the co-registered patch. That means that's the region which shows wall enhancement, which was automatically co-registered. And now we can just identify the area on the 3D surface which belongs to this patch. So which has like a almost no distance or really, really small distance to this patch. And I can now subdivide my surface mesh depending on enhanced area and not the enhanced area. You see there is in green, in this greenish color, there is this aneurysm head. And in the purple color, there is this area which belongs to our enhancement patch. And now I can again have a closer look at the parameters. So we extracted the hemodynamic parameters for this enhanced area. You can see this purple area, and we compare it later on with the whole aneurysm, which is indicated in this greenish color. And then we extracted like the time averaged Walter stress, the normalized Walter stress, the maximum oscillatory shear index, and the low shear area for the enhanced and for the non-enhanced wall segments. And we also extracted for the whole aneurysm, of course, the mean net inflow rate, the inflow concentration index, and the shear concentration index. So this work was and I also we also evaluated some histological biomarkers, but this was not the focus of my presentation, but I will discuss this in more detail later on, because now we have a closer look on the results based on our morphological and hemodynamic parameters. And first, we want to have like a view on the qualitative results. Therefore, we used the simulated blood flow, And we want to analyze how does the blood flow behave in the vicinity of the wall enhancement patches. Therefore, we created another tool where you can just define patches on the aneurysm surface. These are illustrated here in these pinkish colors here, and the arrows are pointing at it. And then we just visualized the blood flow, which is in the near of these patches. And what we could see in a qualitative way is that the flow structures perpendicular to the main flow direction were present next to these wall enhancement patches. So that means that the main inflow, which is so responsible for the inflow chat and the corresponding impingement zone, is not associated with these wall enhancement areas or these enhanced areas, short EA. And we noticed also another finding, that our enhanced areas appeared predominantly at the sites. So just for all cases except for one case, the enhanced areas were on the site on the aneurysm, and only for the one case, this area was at the aneurysm dome. And now I want to have a closer look at some quantitative results. So we conducted a statistical analysis, and we were interested if there is a statistical correlation between our hemodynamic parameters and the percent-aged aneurysm enhancement area. That means we have this area, you can see this purple area illustrated here, and we set it in relation to the whole aneurysm area. And so we get like a percentage size, how much is the percentage part of the aneurysm which is associated to wall enhancement. And there was no statistical significance, but there was a strong trend for low shear area. So that was a really interesting finding. And we also had a closer look about these statistical correlations. And therefore, we compared the enhanced areas with the non-enhanced areas of the aneurysm head. And again, we made a statistical test with our hemodynamic parameters. And now we found out that the time averaged wall shear stress was statistically significantly lower in these enhanced areas than compared to the non-enhanced areas of the aneurysm head, as well as was the and the low shear area and the maximum OSI, these values were higher in the enhanced area compared to the non-enhanced area of the aneurysm head. So this was pretty nice. And this was also reflected by other findings. So we, of course, carried out a statistical analysis of the morphological parameters. And here, many of these parameters were statistically significant with the enhanced area's size. This time, again, we used the percentage size of the enhanced area. And these parameters are pretty common, which have also been associated with aneurysm rupture risk. And we also had a closer look which of these parameters maybe has the most predictive power. So there was also a correlation between among these morphological parameters, and then we could identify the elasticity index to be most important regarding the statistical correlation with the enhanced area. So we also had a histologic evaluation, but for the histologic evaluation, we had the problem that there were aneurysms which were not treated at all, and only for 9 aneurysms, a neurosurgical clipping was conducted due to the medical reasons, so due to the medical treatment. And for these subset, there were only 6 patients where at least one histologic parameter, which is associated with rupture risk, was present. And so we only carried out like a statistical analysis for this subset. But anyway, even for the subset, the presence of one or two of these histological markers was significantly associated with a larger extent of these enhancement area. Again, these percentaged enhancement area in relation to the whole aneurysm surface. So based on our results, we assume that this enhancement area is a possible indication for the presence and the localization of low flow conditions in aneurysm. And of course, this is accordance to literature, so this is nothing new. But what I want to point out that in our study, this aneurysm enhancement was correlated with the hemodynamic, with the morphologic, and the histologic markers, which are all related to rupture risk. So, of course, there was this big discussion about slow blood flow phenomena and so on. And there are really complex interactions between the aneurysm wall and the aneurysm wall's destabilization. But we can assume that the wall enhancement that is visible in the MRI dataset might reflect these complex interactions because the area of the wall enhancement correlates with all these hemodynamic and morphologic and histologic markers. So this is a really, really important finding. And as I already mentioned, of course, there is a problem of the slow blood flow. And our study, of course, has another limitation. So all patients that were selected, the aneurysms were at least evaluated as to be so dangerous that the patients underwent DSA and MRI. So we have a little bias in patient selection. But still, we have these findings. And regarding the slow blood flow phenomena, I also want to show some early results, which is a project which is also supervised by my colleague, Dr. Berg, and together with the University Hospital in Kiel. There was a physicist, and she's also analyzing these slow blood flow in more detail. And the experiment is really great. So from my point of view, they just analyzed 3 different aneurysms, and then they created models. And now we can compare the models. We can compare the signal intensity in the black blood MRI dataset. We can compare it with 4D flow MRI, as well as the CFD simulation. And we can also analyze whether there is a relationship between the signal intensity in the MRI dataset as well as the mean velocity of the blood flow. And I think there are, so the initial results indicate that actually there is a relationship. And so as the previous talk already pointed out, we need a lot of standardization and normalization. And this is also a topic which is really, really important for us. And here was another example where a PhD student from my group is working on a normalized wall enhancement analysis, such that you not only compare it with the pituitary gland, but that you also try to automatically extract like 3D connected regions of the aneurysm wall so that you can carry out a more standardized evaluation. In summary, I think this focal wall enhancement is a really, really great biomarker in these unruptured intracranial aneurysms because many studies could show that there was a correlation with the morphological and hemodynamic factors. And as we showed here, there was also the correlation of the enhancement area with the morphology, with the hemodynamics, as well as the histologic biomarkers, which are all related to a higher rupture risk. Yes, it's also correlated with a higher phases score. And so I think the most important finding of the study that these wall enhancement, even if it's just an enhancement based on slow flow, then maybe the slow flow is just another important biomarker. But these combination might reflect the complex interactions and multifactorial pathologic processes in the aneurysm walls, the destabilization process. And that's the end of my talk, and I thank you very much for your attention.
Thank you, Sylvia, for this very fascinating talk. And also, I would like to thank you for all the speakers in this morning session, to Ashrita, Owais, and Sylvia again, for very fascinating talks and results. And now we can proceed with the discussion. We have a couple of time for many interesting questions from the audience, either here in the virtual session or by chat.
Yeah, I will. I kind of start the discussion with a question for Wise and Sylvia. You know, as both of you mentioned, it's very important the normalization because basically we're using different scanners, different techniques, even sometimes the timing of when the contrast is injected, and we've been trying to be consistent in acquiring the database here at University of Iowa. We try to do it. T1 post 5 minutes after injecting the contrast. So all of these different technical variables can affect enhancement. So what do you think would be, well, I mean, we in our analysis, we did normalization with the corpus callosum, and also we've been doing normalization with the pituitary stalk. And even in doing normalization with the pituitary stalk, we use maximal signal intensity versus mean signal intensity. What do you guys, in your experience, you think is best for normalization?
I don't have personal experience with actually normalizing by pituitary glands, but you know, I think it needs to be tested whether with max or average. So you can probably segment out the entire region and take the average of that. That might be one way to go, but I'm not really sure. It would need to be like with all other quantities and using a bigger data set to establish this. I think there's already a study. I forget the name of the study you cited in your paper from, I forget the author, but yeah, but I think it needs to be with mean, I would say, of the entire segment.
I would also suggest that due to our findings, you take into account the amount, the volume of the enhancement, not only if it's maximum or mean value compared to the pituitary stalk, but also how large these areas are. And maybe we, based on our studies, we also want to include like the heterogeneity.
Yes, so it was a time and SAC average quantity. So that's the parameter we used. So as I said, we used a few other quantities such as OSI and normalized. So we normalized the wall shear stress and SPI, but none of those actually correlated with wall enhancement. And that's the follow-up question from Dr. Berg. So SPI did not really show correlation with wall enhancement. So it might, so there might be a different mechanism that might be happening with aneurysms that show SPI and compared to the wall enhanced aneurysm, and that needs to be further investigated. I'm actually working on a study that's going to come out in a few weeks or maybe a couple. I'm trying to get it out. That might be really interesting. That compares SPI in a larger data set.
Question, also a third question in the chat to Sylvia. regarding the segmentation, would you consider using MRI instead of CTA? In your experience, how comparable in accuracy are the results obtained from DSA when compared to MRA?
So we work with both modality. If it's possible, then I prefer 3D DSA because of the higher resolution. For example, in our study, the resolution of the 3D DSA dataset was 0.27 times 0.27 times 0.27 compared to the MRA data, which has like 0.75 millimeters times 75 millimeters, 0.75 millimeters. So I would suggest to use the image modality with the best resolution, because we all are also interested in the aneurysm neck. And if you have a low resolution, then yes, aneurysm neck and the morphological parameters are not so good. But if there is nothing else available, then also MRA works fine.
Thank you. Further question, further remarks, comments?
I have a question for Ashrita. I think one of what everybody is looking is into having a semi-automated method to really analyze large data cohorts. How time consuming is doing the segmentations and the volume analysis with your method?
Well, I think we were using MRA data, which is low resolution. So part of the time-consuming part of the segmentation is really determining what's noise and what's real signal on the MRA. When you have higher resolution like DSA, the segmentation goes a lot faster. It's pretty clear what your aneurysm, what your lumen is compared to the noise, assuming there's no artifact. I think the VMTK semi-automatic segmentation is definitely quicker than complete manual segmentation, because you can kind of investigate and set thresholds and create a methodology based on those thresholds. So I think does that answer the question a little bit?
Yeah. I think so. Basically, demands a lot of manual manipulation and time to really clean the data. So we're, using this tool seems like it's still far away from getting a semi-automated method.
Okay, thank you. There is also a question to you, Ashrita. To what extent can small percentage changes be explained by aneurysm pulsations? What do you think?
I'm not sure how the MRI or the MRA captures pulsations, since it's technically a picture. I don't know if anyone else has any thoughts on how that would be captured in the image data sets itself.
Okay. That is a nice comment. Yes, maybe Sylvia can comment this.
A suggestion. So what I would also like to do, but I don't have the data, would be like if you have a 2D sequence, a time series of the aneurysm, there sometimes you can see the pulsation. And what you can maybe do, or what I would love to do, is that you make an analysis in 2D about the pulsation during time, and then maybe you could extract some interpretations for the change in volume over time.
So just to add to that, so what Ashrita showed was very interesting, but I noticed that, when you're looking at the, and this goes back to Suresh's comment, so when you're looking at the changes, right, so some of them show a 16% change in volume, right? So that would be, if you look at actually in terms of just one axial dimension, that would be, so because volume, if you look in the volume changes, that kind of elaborates and the total change, right? So if you just look at in millimeter, you have to take a under root of 3, right? So that would be about 16 would be about 3 to the 9. No, maybe about 2 to the 8. maybe 2.5 or something, 2.5% change in actual dimension. So if I'm understanding Suresh's comment, like, is that because of pulsation, or is that because of real changes in the volume of the aneurysm? So I don't know if you have comments on that. No, okay, yeah, that's fine. Because some of your aneurysms did show large changes, like one had about 52%. So that might be an actual change in the volume of the aneurysm rather than just an effect of pulsation.
Right, and that's one of the parts of the study. We haven't defined what growth really is in terms of that percentage change, and trying to find the similar metric, because you can find percentage change, like you said, in the linear scale, but then it completely scales up when you go to volume by an order of magnitude. So determining what cutoff what cutoff means growth is something we're looking into, comparing to the 2D measurements itself and saying, is this growth clinically, is this growth, and then what percentage change of volume is that?
Yeah,
I mean, but this comes back to the question, if and this is mainly for clinical studies, do you guys think among the panelists that volume change should be reported on 2D versus 3D? I mean, volume aneurysm growth should be reported as a 2D measurement, or really as a 3D volumetric change?
I would definitely suggest a 3D volumetric change, because due to PLEPS, or as we already expected, if you carry out a 3D analysis of the maximum diameter, it's just different to the 2D measurements. And so, because it's possible, I definitely would go for a 3D.
Yeah. There's a bunch of questions. I don't know, with Gabor, you want to go in there?
Yes, first of all, thank you, Suresh, for the encouraging words to the speakers. Nice talks to all of you. And there is also a question to all of you. Do we have an idea of repeatability of wall enhancement imaging? Has there been such a coffee break study, really? Anyone planning one? So, nice question.
Yeah, I think there are a lot of ideas. We should definitely do it, and because it's not very difficult. And as I told you in my talk, we should automatically detect the areas. I also like the idea of Mr. Khan, where you had these normalized arrows outside from the aneurysm. So I would suggest that you first segment the aneurysm, then you go in normal direction outwards. And I would also suggest to use this normalization with the pituitary stalk. And in doubt, you can just do both, like using mean and max values.
So going to this question about repeatability, there is we did 9 aneurysms with 2 scanners, 3 Tesla Siemens and 3 Tesla GE, and 7 Tesla GE. The same patients with the same aneurysms. Obviously, we couldn't do it on the same day, or I think they were done a week apart because of the gadolinium. These were like 9 brave volunteers that wanted to have 3 scans. And it was interesting because we normalized it to the pituitary stalk, and they were very, very similar, the results. So and this is thinking in the future, if you can use this as a biomarker for instability, and it seems like you can, at least based on this short experience with 9 patients.
There is another question to Ashita. You showed size can decrease while volume increases. What is the value of increased volume while decreased size? Tells it something about rupture risk? What do you think?
I don't know if it's a measure of rupture risk more than it's showing that the 2D, the measurement, the size measurement that you have did not capture fully the morphological change that you saw. And that's why there are like so many parameters, like 20 different morphological parameters. And the idea was that volume can engulf all of those parameters to give you kind of an overview of what's happening in the aneurysm. And if you're more interested in specific changes in one dimension or one plane, you can look at those 2D measurements for more information.
Okay, thank you. Then next question is from Philip. Interested to know how threshold between noise and significant shape changes. Can somebody comment this thing, how to select the threshold? What is a good threshold, which is also good for repeatability?
So I'm not sure. So is this threshold when segmenting the vessel wall MRI or just normal images like the 3D rotational angiography?
I would guess there is a following question from him, and I would guess this. I don't know, but I guess this is for the signal to determine whether we have vessel wall enhancement or not. So I would guess the threshold is here related to the vessel wall signal.
Yeah. So so that issue comes back to actually coming up with the threshold. So I did for my study was just normalize the volume stack, which is probably not the most ideal way because that can change quite a lot based on the scanner. But I think that needs to be investigated what the ideal threshold is for the vessel wall MRI to distinguish between aneurysms, because the best study would be like a prospective study where we actually look at aneurysms that grow and then come up with the threshold. So in my study, all of my aneurysms, I just had one time point. So the actual true threshold of what can actually predict which aneurysms are going to grow or not, or actually rupture, is very difficult unless we do some kind of prospective study.
Okay, thank you. Edgar, maybe the same question to your group. You have used different devices, different resolution. Do you have some uniform threshold to characterize vessel wall enhancement?
Yeah, so that's when you talk about threshold, you wonder what's the gold standard, and we analyzed, I think it was 160 aneurysms, and we used for gold standard data from ECUIA, which is the 7mm cutoff, because as OI said, usually bigger aneurysms tend to enhance more. So when building the area under the curve for 7mm cutoff, the threshold that performed the best was 0.6 for ratio. That's mainly dividing the pit stock by the enhancement. But
Okay.
then you have several questions, and this is why Sylvia's study is interesting. What you do, normalize the circumferential wall enhancement or just the focal enhancement, because there's studies from Omodaka saying that you have to do it with the circumferential wall enhancement. What do you think, Sylvia? You think we should use circumferential, or we just go for focal and trying to identify in 2D imaging different views the area of more focal enhancement for analyzing enhancement of aneurysms?
Sorry, can you explain the question, please?
So there's different ways to analyze enhancement. Some people do the ROI around the whole circumference of the aneurysm, and some other authors like your group recommends doing focal enhancement, because there are areas that don't enhance as much as the other areas. When analyzing enhancement, you think you have to do this whole circumference of the aneurysm, or you got your analysis more by the focal enhancement to determine if an aneurysm is unstable?
I would suggest to use the whole aneurysm. And so in a bigger picture, it would be great to have maybe like a score that depends on both, like on the focal enhancement as well as the circumferential, so that we consider both information.
Thank you.
further comments, further remarks, questions? I missed a live discussion from a face-to-face conference, but at least good to see well-known names here in the chat, at least in a virtual space. Further question, remarks?
I just think it's very exciting that there's so many groups working on the same issues, you know, wall enhancement and trying to correlate that with CFDs. You know, as we mentioned before, I think prospective analysis and you know, I think there's a couple of studies going on will give us more answers, and I definitely think there is a component of artifact, flow artifact, because some of the images that you show, Sylvia, at the end, that you have this signal of enhancement of the middle of the aneurysm is probably related to flow artifact, stagnation of contrast inside the aneurysm, and it's something that you see sometimes with larger aneurysms. But sorting what's the artifact versus what's real is challenging, especially because of the size of the aneurysms. And I think you know, works like the one that OY is the building these 3D maps is like what we're looking at of the future of enhancement. See the whole picture of the aneurysm and see in the 3D map which areas might be weaker. And we know aneurysms behave differently based on the etiology. Also, some of these atherosclerotic aneurysms have thicker walls. So they might enhance because of different reasons as opposed to aneurysms with thinner walls.
And to add to that, so if there's somebody interested in sharing their high resolution data set, then there might be a grant that can be written to actually quantify, properly quantify, because the tools I developed are mostly just I wrote them, but I think there's a lot of room to actually make these tools more robust and make them open for the community. So yeah, so I'm open for collaboration if somebody's willing to share their data set and we can write a grant.
Nice. Maybe just a comment to what Edgar mentioned. I think we have worked on CFD for over more than 15 years to find the reason and the correlation between rupture and morphological or hemodynamic parameters, but we couldn't found this up to now. So there is no direct correlation yet. And now I think the next logical step is really to find some correlation between the wall information and the CFD. And this is the next logical step. And this is nice to see that many groups are working on this area. I love this session to have nice talks and to show the state of the art in this area. I think this is the next logical. We cannot neglect the role of the wall, and we have to understand this much better. So perhaps we have to really add something additional to the CFD, maybe vessel wall imaging, maybe something else. But I think this is one of the next big challenge for the community and for the next years at least. Good. No question. Okay.
Do you, in your analysis, did you see more enhancement in these areas of focal enhancement in areas maybe of atherosclerosis, or there was no relation, Sylvia? It was mostly related with blebs, or?
Yeah, there was a correlation with, for example, with an increased ellipticity index, and so with blebs, therefore, if an aneurysm has PLEPS, then the correlation with the enhancement regions is increased. And regarding the artifact signals, so that's a really, really interesting research topic. And so we are working together with Dr. Larsen, and she always says that the problem that we have the enhancement of slow flow, maybe that's not a problem. So in the computer science, you say it's not a bug, it's a feature. So maybe we cannot only use the enhancement imaging to enhance the walls, but so the enhancement of slow flow, this might not be a bad thing. Maybe we can exploit it and we can integrate it in our analysis.
Good, thank you, Sylvia. Further remarks, further comments?
Well, I think we have tomorrow there is a session for CFDs.
Yes.
So look forward to hear from other groups like Sebral and groups in Japan that they've done a lot of work also in CFDs.
Yes, this will be a nice complementary session to this session today. I've seen that Pedro is already online. Just sending greetings to Argentina.
Hi guys.
Hi Pedro. Nice to see you again, at least in the virtual space. Good. I think now we can close this session. Thank you again for all the speakers, to Ashrita, to Owais and Sylvia, for very fascinating talks and also for the discussion. And I think now we can proceed with the next session, a special session, a Pedro session.
Okay.
So we start with Pedro. He's the one of, together with Daniel Rufenac, they started this conference years ago. He will show us the experience of Buenos Aires with the pipeline and the treatment of aneurysm is to validate all the experience we have with different devices working in the clinical domain. Please, Pedro, can you start with your conference?
Okay, guys. Good morning, good afternoon, whatever. It's a pleasure to be here with you and listen to that interesting discussion. Here I am, one of the dinos of the ICS. So it's my pleasure just to show you our experience with the interesting topic that we have been working during the last 13 years. So that's my disclosure. I hope we can go over a little bit about the history of flow diversion and see if we can get go over clinical cases, see what our complications are, and try to get some conclusion at the very end. So it's very interesting because sometimes we tend to focus on the aneurysm or what the device. I think for accomplish our task, we have to focus mainly in the aneurysm. And I will show you our experience. I try to share our experience in Buenos Aires, in our center. I must be really acknowledged to all my team during those 13 years. A lot of people have been involved with me in this experience, and I would like to thank all of them. We still are doing around 40, 50 cases of aneurysm per month, but we are using, as you can see, more and more flow diversion rather than only coils as we used in the past. We found our way with stenting back in 1996, and that was, we will discuss a lot with Daniel at that time. The first meeting was take part in Geneva back in 2003, Geneva again in 2004, and after we have the pleasure to go around the world until today that we expected to be in Galapagos, but unfortunately we are somewhere in the virtual world. But it's okay. I think we have done a lot of work. A lot of people have been involved. This is Geneva back in 2003. This is Herman a couple of years ago, working in Geneva with us, and Makoto is behind, as you can see there, and the lab with the models at that time. So how the idea of flow diversion went out? Thanks to the vision of I.J. Wakalu. He published that paper, that I would say that seminal paper back in 1996. And also thanks to the Geneva team, I think the contribution of Daniel and Makoto was essential to understand a lot of things about. Nelson, Peter Kim, and Aaron come out with the first device to show us that we can modulate the flow. We can modulate the flow in several ways. Maybe I can show you, hopefully my video, well, it's not going to work. But not only we realized that this is important, we can modulate the flow, also the company realized that. So that small company called Chester was bought by EV3. EV3 was bought by Covidian. At the very end, Medtronic came to the banquet. Our personal history in Buenos Aires with the flow diversion started in 2005. We went through all of the classic and also the flex history and the shield at the very end of the history. So we realized that we need something else than coils very early on. And we went to flow diversion to repair the flow. That was a whole concept at that time. Today is clear for everybody that we have to reconstruct the artery, but at the beginning was not that clear. And we evolved from the classic PET to the shield PET, and we will see some cases about that. We also evolved on the concept that a lot of company comes with different products. Some of their we call that 5th generation. We can see better now, the device is clear even with the MRI, and we have some surface modification like shield or HPC. Why is that? Why we always need some devices? Well, because we have to understand really the questions. We have to understand that as we realized at the AC meeting, the formation, the growth, and especially the rupture of the aneurysm is a very complex problem. It's not easy to understand. There are internal conditions that are very important for us, like as neurointerventionalists, and there are external conditions that are underworld conditions, which are very important also for neurosurgical, for our colleagues. And of course, there are different aneurysms. There is a rupture aneurysm that will fit with some of the devices, and you will need to have also different, and we have to decide if we are going to treat or not on rupture aneurysm. But I think the most important thing is to understand the concept. Which arteries do we need to reconstruct? And those are the segmental arteries. We understand that with Makoto, Ota, and Daniel very early on in experience, we come up with those concepts. The segmental defect is something that involves more than a quarter of the vessel circumference or the same distance and length, which is important. This is the way that we start. This is a segmental defect. As you can see, 3 aneurysms in a row in this one single segment. At that time, we were using the Fargo device, a Marksman like a catheter. And this is 1 year follow-up showing the reconstruction that we have and the disappearance of the triangle. So we understand the concept of flow modulation. What that means? Well, if you have a case like that, where you have, again, 4 aneurysms in a row in a single segment, we use only one single device to reconstruct, but as you can see, the ophthalmic artery comes out from the base of the more proximal aneurysm. So what happened here? Well, they really modulate the flow. Again, sorry, we cannot see the video, unfortunately, but you see all the aneurysms already have got 9 months after we implanted one single device. Well, this is a clip which is in the contralateral side here. But all the aneurysms has been gone. This one, it remains open because flow goes through inside thanks to the ophthalmic artery that aspirate everything. And it remains open, you see, it shrinks, but it remains open almost 6 years after. So this is a whole concept of flow modulation. I will show you the same thing, but with another approach. That lady blades, the young lady blades, we went in and tried with coils this ophthalmic aneurysm, and aneurysm recanalized. So we have to reconstruct the artery with a very small pipeline, 275 by 14, and that time, as you can see here, this is a recanalization there. This is 3 months after the aneurysm is already gone, but the artery, all the arteries remains open. So there is flow modulation through it. So the concept of circulatory exclusion is very important, as well as the reconstruction, as well as the maturation of the flow inside. This is an important part in that we didn't pay attention for the beginning, but which is very important with the time being. We understood that, unfortunately, with some complication. So at the beginning, we were looking for indications, what kind of aneurysm we can treat. How the other question was, the challenge was, how far can we go? What will happen with the symptoms, especially in the giants? How long our relief of those symptoms they last? What will happen with the hemorrhagic complication, early, late complication? And also very important, what happened with thromboembolic complication, because we will jail arteries and we will put small devices inside the intracranial circulation. So we start with a very complicated aneurysm with severe segmental defects, some dissecting, some fusiform, but basically we start with giant and large, or with the wide neck. We call those complex aneurysms. During those 13 years of our experience, we got really help for the development on interventional treatments, not only on devices, but especially in image visualization, new tools, and bioinformatics that was applied to clinical and research consortia, and especially translational research. We can see better now. You see how nice we can see the relationship between the artery and the device. We can see if the device is well opposed, is it open proximal, is it open distally. So we really can see much better. And also the other important question that we got help was from bio for our friends from CFD. I have the pleasure and privilege to work with our friend Juan Sebral, and really we learned a lot for him, not only on the issue of what will happen with the jailing artery, but also if we can predict what will happen with the occlusion times, was also an interesting question to answer. And more recently, can we predict which one is going to rupture or no? So we really appreciate very much the work with Juan during those years. So we start our clinical experience with we did a pilot study after we were part of the PITA study, and after we start our own study called Pedestrian, that we would like to share with you our experience with the first 1,000 aneurysms in that particular segment of people. So our experience today is a little bit more than 2,000 devices have been implanted in Buenos Aires, but I will focus my experience now with those years just with the pedestrian. That means only with the pipeline. We were touching more anterior circulation than posterior circulation, as you can see here. The most frequent aneurysm that we treat was saccular 84, but also we have experience with the dissecting and fusiform aneurysm, as you will see. 1/3 of the cases were large and giant with a big neck. And the mean devices that we were utilized was a little bit more than one. We start with several devices, but with the experience, we use less and less devices in one single patient. Our mortality rate is today 5.8, less, I would say 6% overall. And after, in our travel, we got the green light of that we are trying patient with something which is a usual practice as routine with less questions. Here are some of the devices that we have experienced. not only with PET, but with another ones. But mostly, I think we have experience with PET. And we learned that we are very safe. As I say, less than 6% of morbid mortality. We are very efficacious. At 1 year, we have around 88, 90% of occlusion rate. And we have, I will show you some long-term follow-up. This is the first case that we treated in 2006, was an AVM combined with an aneurysm that has several coils inside, as you see there. So we treat first the AVM, but because bled, this is post-treatment of the AVM. The AVM has been gone. You see the sizing of the arteries went to the normal. And after we take care of the proximal aneurysm, that was the reconstruction 6 years after. Those artifacts come from the coils. Again, 6 years of experience. Do we have long-term follow-up? Yes, we have. I will show you some cases. This is how stable is that the treatment 2 years right after. This is another case. This is a giant aneurysm. Here you see only the lumen of the aneurysm. You see how big, with a loss of mass effects. We implanted a small pipeline 3x18 at that time. You see how the mass effect went down at that time. This is the last one that we have. And see also how modified when the mass effect went down. You see the modification of the pipeline 3 years after the treatment. You will see much better here with the simultaneous injection of both sides. You see how less mass effect we have there with this giant aneurysm. So I think we have to pay the price for new devices. And the price is we have to follow our patient. At the beginning, we follow those patients only with DSA. Today, we are following most of them with MRIA, in some occasion with CTA. This is another case, is more proximal, long-term follow-up, carotid ophthalmic one, again, 7 years. So I think the pipeline embolization device demonstrates very high closure rate in the follow-up. The other question that we answered with the time being was, can we treat more than one size with pipelines in one single patient? Well, those are two dissecting giant intercavernous, the right and large on the left, and also has a dissecting and the vertebral right vert. So we implanted three devices there. You will see one on the right, one on the left, and this is in the vert. So that was possible. The patient, of course, remains 1 year on antiplatelets and after an aspirin. So at the beginning, we were talking here, the complex aneurysm. So well, if I ask you guys, what is the definition of complex aneurysm? Each of you will have several definitions probably. What that means? For me, mixed means difficult aneurysm to treat. That is complex. Not only the giant, but some of very wide, very small with the wide necks also are very difficult to treat. So show you just some of the complex. This is a lady with a giant aneurysm. You see mass effect on left and also on the right. The A1 here was absolutely compressed. She was almost not feeling from the left. So we were able to go from the right, cross the anterior communicating artery. Sometimes one of the most difficult things to do is try to find the exit of the aneurysm. Here we were lucky. We used 2 wires, one in the anterior circulation, one in the middle artery circulation. We have sufficient anchor. We bring 3 flow diverters there. You can see immediately after the third was implanted, there is a stagnation inside of the aneurysm. And here there was some spasm on the right. As soon as I pull my system, everything went back to the normal. And this is immediately right after. This is 4 months follow-up. You see how already the mass effect is less. And this is 1 year follow-up showing the disappearance, the complete disappearance of the aneurysm thanks to the remodeling of the artery. There was at the beginning also an issue, what will happen with the transient stenosis that can affect and how bad that will be. With experience, we learned that that happens around between 7 and 10% of the cases. But if we keep the patient on the antiplatelet drugs over the time, will disappear. Most of them disappear after 1 year. I show you one case with a giant again, with the most effect, optic nerve on the left almost was gone. We succeeded. We treat that with 4 devices, but you see 3-month follow-up. There is you can see some stenosis there. It was also 6 months, but at year 30 it was almost complete resolved. So in those 13 years, a lot of things evolved. With the pipeline, the company comes out with the FLEC technology, and today we are using PET technology and Shield. I hope sometimes we can do that meeting on the Iguazu Falls and northeast part of our country. Hopefully we can bring ICS back to Buenos Aires sometimes. So that was the evolution over the time. I must tell you that is really improves a lot. Today is much more easy to open the distal portion, and really you can reshift the device almost 90%. So that was a nice evolution on comes with those sleeves. The device opened very nicely and conforms very nicely to the form of the artery, which helps a lot. There was a lot of papers with that technology already. The conclusion was always is overall low rate of major complication with this device if you compare with the first. But the nice thing about the Shield that finally we succeed to convince the company that we need some surface treatment. I was trying to convince them with Daniel from the beginning because we saw our complication on day-to-day procedures. But finally, the company with the surface modification with the phosphorin choline was covalently bonded to the device. That was called Shield technology. And I must tell you that also there was a lot of papers out. I think I like very much that from Matthew group from the UMass, showing that modification of flow was associated really with less thromboformation on the surface of the device. But to say that, you need to see the device, and that is possible because the OCT. That's important. I mean, you have to use intravascular device, image device, to see if you have thrombus or not. And that was accomplished very nice by elegant way for Matthew groups. You see how nice opposite around, and also you see there is no thrombus formation around, and there is a very nice healing of the aneurysm. So that was a very nice papers. Some preliminary experiences were done by the Australians, by Manning and Wendero group from Australia, trying to use in the hemorrhagic group. I show you a couple of cases with that technology. This is one case that we have to reconstruct everything from the supraclavinus down. I think we use seven devices here, in device technique. We were able to reconstruct everything. This is 1 year follow-up showing very nice reconstruction. So I would like to show you some giant. This is one of the follow-ups on the segmental, of the ophthalmic segmental. You see how you diminish the flow effect. And again, this is another one with 2-year follow-up, 24 months. That is, you're showing how you decrease the mass effect, and really you have a very nice correlation with the remodeling of the artery. She was a ballerina. One really thing that we pay a lot of attention in the follow-ups are our protocol or those giants. Those giants, we pay special attention for the arterial blood pressure. I think this is one of the problems. So we use steroids on some of the patients that they came already with the symptoms, or when we worsen those symptoms, we use solomedrol for 3 days, and after we keep on deposit steroids for 1 month. We have treated small arteries, especially those that already were treated by clipping, was not resolved, so we implanted just a small flow diverter. This is 6-month follow-up. showing nice remodeling. And this is another case where the dissecting, as you see, there is two aneurysms here, one distal, one proximal, that we just implanted one device in the carotid, and this is the follow-up showing that the artery remains open, and also the ACA remains open, and the patient was cured. We have treated also some posterior circulation. As there are more and more papers now coming, we were very conscious of that. We treated especially dissecting aneurysms. I can show you one with a thrombose, partially thrombose, that was fed by both sides. So we just occluded the left side. We keep open the right side. We reconstruct the basilar artery, and here you will see some fusion. This is 7-month follow-up in that particular patient. And you see the patient was okay. We followed them until he was growing, of course. Another concern that we have at that time was the jailing arteries. What will happen with the jailing arteries? We will jail a lot of artery for the posterior circulation, anterior circulation. The segment that we have more jailing artery is the choroidal one. We never have a problem there, but we do have problems, especially in the posterior circulation. I would like to show you one case that was a dissecting one that was treated with coils at the time of the bleeding, and after a neuroform because of recanalization, we ended up with using a small pipeline. The angiographic result was very nice, but I must tell you, the patient developed brainstem infarct. So that was one of the cases that we have one for like a complication. We were reluctant to use in the bleeding cases flow diverters. It's clearly not our first option for treated patients. Other alternative has to be considered, like a first, the coiling is the base. And after in the second stage, you can treat it. But in some occasion, you cannot put coils, like this very small aneurysm from the posterior circulation. You can see there that we ended up with crossing with a flow diverter to the left, as you can see there. And this is 6-month follow-up showing the disappearance of the aneurysm, as you can see in that slide. This is another case that bled and rebleed. Was a dissecting, as you can see here, it's a dissecting aneurysm for the pica artery, from the right pica. We were lucky to end up at the level of, with the proximal part at the level of the vertebral artery. And this is a nice reconstruction of the pica. This is follow-up showing almost 2 years that the treatment is durable. And some blister lights from the anterior circulation, we treat those in the acute phase. This one that bleed and rebleed again. You see the progression of the blister because here was the thrombus recanalized. So we decided to jail a catheter here, put some coils there, opening after we open the flow diverter, and you can see there. So we use 3 flow diverter for the immediate occlusion of the aneurysm. We put those patients with agrastat on the table, and we keep them on ticagrelor right after. This is just to show you the MRI, showing there is no deficit in the diffusion. And this is 6-month follow-up, showing nice occlusion of the aneurysm. We also, at the beginning, were reluctant to treat bifurcation aneurysm with flow diverters. And our say is almost less than 6%. And the issues were the lateral branches, if we have to use coils or not, what will happen with the occlusion rate. So I will show you one case with a left MCA that was ruptured. We did first with coils, recognized, and after we had to use a flow diverter. And this is 26 months of follow-up, showing the artery remains, all the artery remains open, as you can see over there. This is another interesting lady that she bled, rebleed, were treated with coils first. You see the coils and the thrombus portion. So we coil again in the acute phase, a lot of coils. We did the angiogram She was still in ICU. We did the angiogram, everything was open, but also the aneurysm was again open. So coils, we decided to use even there was a bifurcation, a small pipeline, and you see the artery remains open at that time. And that's, you will see the follow-up 14 months after we treat. She really did a big fight for the life. She was vasospastic. We use a coaxial system on her, dual balloon to increase the perfusion on the brain. But she did very well. At the very end, she recovered nicely. Distal aneurysm. Sometimes when they're dissecting, like in this case, you can treat it with one single device. This is 7-month follow-up, showing the stability of the treatment. What are the limitations? Of course, we have limitations. We always have some limitation in our techniques. Access is one limitation. To find the exit of those complex aneurysms, you have to use additional techniques like balloon distal, stent distal. Also the length. Until at the beginning, we didn't have that many lengths. Today we have 50 millimeters in length, which is very good. But also we face some problems with the shortening, and we can have some bridge disruption. So that can happen, really. That can happen, and you will shorten your construct inside the aneurysm. And you will in problem because you have to fish to find, again, the proximal portion. So the rupture is big, it can be a problem. I show you one case. We were very happy here. We almost did a great job. But I tried to massage the bridge inside with the device. I ruptured the bridge between the first and the second stent, as you can see there. So I have to came back with another device, which called elevator. That was the situation. So I grabbed the distal two with the elevator. And I took them inside of the aneurysm, and I was able to reconstruct. I was lucky, I think. I was able to reconstruct the artery again distally. So 4 devices, one is telescopic, one inside another one, and this is the patient a year follow-up. So that's. One of the limitations remains, at least in my hand, is if you have a stent that was previously implanted. You know, some of the times the laser-cutted devices, even the braided, they are not conformed nicely to the arteries. So you have leaks in between. When you have leaks, no matter of how many devices you can implant, the device, the aneurysm will remain open. So here is one of those cases that we coil a lot. We implanted first PET, we implanted second PET, but because an enterprise was implanted first, you see the aneurysm was still open 2 years follow-up after the second one. We follow up. I was really reluctant to put another device. Was stable, but you see the lumen portion was growing. Also complication. We did have complication, of course. The biggest complication is the bleeding, the immediate bleeding, the subacute bleeding, or the delayed bleeding. Why does aneurysm bleed? Well, there are several theories on that. I think this is a very nice revision of Dr. Wakalu on the delayed rupture. I think the hemodynamics mechanism can play a role, but also the thrombus is a living animal that is not helping us a lot sometimes because the clot burden may release inflammatory markers and break down the aneurysm wall. That was discussed very nicely today in the morning. I think the inflammatory, the enhancement of the wall is something that we have to pay more and more attention. But don't forget also what kind of aneurysm are we treating. We are treating really complex aneurysms, and the natural history of those is very bad. I mean, 5 years, 80% of morbid mortality. So the explanation of that can be one for the delayed ipsilateral hematoma. And I also had some ipsilateral contralateral hematoma. Sorry, some contralateral hematoma. I think it's an issue of dual antiplatelet. So what is the solution for those bleedings? Well, filling aneurysm with coils, more than one vasodilator, keep the blood pressure under control, and take a very, very close look on what kind of regime, dual antiplatelet regime, you have. But I think the more question will come from new devices with the surface treatment. Regarding those bleeding, you can have acute hyperacute bleeding, some acute bleeding in first 24 hours, but also you can have 1 week bleeding, and also we have bleedings until 1 month. And I think those are because you have really a proteolytic activity on the wall, as was explained. So I will show you some of our first bleeding. That was a lady which the procedure was eventual. It took us, we have to do a dual, we have to do a 360 maneuver inside the aneurysm to take out the exit to breach the aneurysm. At the very end, almost everything was done, and we were very, very happy. I say, okay, let's do a last run, and during the last run, you see the bleeding on AP view, and also you will see the bleeding on lateral. So that was really a problem. So our first case ended up with a ranking 6. So we published that with Juan Sebral, trying to find some assessment from the hemodynamic analysis at that time. And also we were looking for the hemodynamic and also the pressure in that regards. So a lot of people were using coils, additional coils. On the next case, we say, okay, that was we have coils already in this patient because the patient bled. After we wait 3 months, and we decided to implant a device 3 months after. But the problem was, you see the stills, the distal portion, the flow is still impinged the wall there, and of course we have this is the device implanted very nice around the artery. But if you see that unfortunately the patient bled 30 days right after. So the coils it can be an advantage, can be really help for us, but I don't think it's an answer. I think this is a perfect storm with several actors: the hemodynamic, the history, the biomechanics, but also the environment will plays probably it will plays a role in that. I think also on top of that, we are adding our antiplatelet regime, which is another problem sometimes. We have been using clopidogrel at the beginning. Today we are switching, we use prasugrel mainly. In very few cases we have used ticagrelor. In acute, when we have a problem in acute for the patient, we use abscissimab or agrastat, tirofiban. And I think that is something that not a lot of people pay attention. I think hypertension is the most powerful risk factor for formation, followed by hypercholesterolemia. So we have to keep on that. The wall and the enhancement was really discussed very nicely in the morning, so I will not keep on that. I must tell you that with a lot of my experience, we still are looking for a high flow diverter. Today we have some of those tasks have been accomplished. We have a very nice small devices. We have several sizes. We don't have devices 7 millimeters in diameter, which I think are important. Maybe not the 7, but the 6 is important. Sometimes the proximal artery of the patient are bigger than 5. Today we have full retrievable devices with surface modification. We still are hoping that there will be new devices better. So a lot of those tasks has been accomplished. I must tell you that the shield technology helped us a lot. So what our conclusion after the 13 years, Well, I think it has been a fantastic experience for the patient and for us also. When you pass, there is a learning curve. Definitely there was a learning curve. When you pass that learning curve, it's very handy, feasible to use, very fast. We really cure a lot of patients. We got less radiation than with 100 of coils, and the procedure is really fast. So we have to go patient by the patient. The decisions in medicine are not easy, and there is no magical receipts like for chefs. So I think the thing that we have still to understand better in the healing mechanisms and thrombosis, that is something that remains. Somehow our conclusions are summarized in a nice paper that Fiorilla put with Sikora, Albuquerque, McDouglas, and Dawson. I think that we have a current body of evidence and experience that is a fantastic device. Of course, we will have more and more experience with the new devices. So saying that, I will thank you again to the audience for being there, and especially Herman, thank you for the kind invitation. Hopefully we will have a next ICS meeting presential. We will go together, we will socialize as we used to be. So thank you again, and hopefully you have a great World Stroke Day. Now remember, what are you going to do today for stroke? This is the meaning for Stroke Day. Thank you very much for your attention.
Thanks, Pedro, for this excellent talk. I think maybe there is some questions going up. I feel like maybe you like to, in the use of a pipeline or the devices into the big aneurysm, giant aneurysm. There is something that when there is very acute thrombosis, you will see a growing up of the mass effect. Have you used something to manage this problem? Because when you have a big mass effect, you can have different kinds of flow, and maybe you can have some problems to manage the patient. How is your idea when you have a very, very acute thrombosis and a big mass effect from a giant aneurysm?
Well, the mass effect you can manage with steroids, as I explained with the protocol, but the issue of the acute thrombosis is a dangerous one. We learned that when we review all of our bleedings, I think half of them were completely acute thrombosis. There was no more inflow inside of the aneurysm. But we know that there is always inflow, there is no outflow. So we increase the mass. When we increase the mass effect, there is of course we can increase the pressure. So it's something that, you know, what you are working with the young people with you, the people get very happy because you occlude completely the aneurysm. But then the giant, and as you pointed out, this is not a very good idea, because you will have a lot of proteolytic, probably enzymes, and digesting the wall there. So, but we are routinely using now the steroids for 3 days, the solomedrol steroids. For 3 days, we pulse them. But I agree with you, it's not very nice. I prefer, that's why we stop also to, you know, at the beginning, people were advocating a lot to use more than one pipeline. There is no need of that. We got very nice result with one single device, and that's how we also we allow some kind of interchange between the interface between the artery and the aneurysm itself. And this is especially true on the giants. The giants are, as I said, are complex to treat.
Thanks. Thanks for sharing the pictures of Herman when he was younger. That was very unique, and also from Dr. Rufenack. So one question, Dr. Lilig, you mentioned that the pipeline shield technology decreases thromboembolic events, but you still do dual antiplatelets. One of the things that Medtronic advertises is that somehow the covering of the pipeline shield makes it easier to deploy. Is it something that you found with a new pipeline shield that is easy to deploy, and maneuver as compared to the older versions because of the covering?
Yeah, of course, it's 100% much more easy. Regarding your first comment, I think, please believe us, we were young, like you before. Herman, I remember Herman was a very nice young guy working with me on the Animal Lab in Geneva. He spent a year there. So remember, we have some pictures to prove that. That's first. Second, yes, no question about. There was a big difference. The Classic, if you compare the Classic with the Flex, the Classic was more easy and smooth to go. The Flex was something compromised in between, but the Shield, the hydrophilic coating makes a big difference. It's flying. It's a big difference. I think this is one of the best things regarding the Shield technology. And as well as others hydrophilic technology speed up the procedure. Really, even if when you have those very tortuous anatomy that you really need to have very proximal support, you need a triaxial system, and even though you cannot get there, if you switch for Shield, you will get there. Really is we need something like Shield, but to fit in small microcatheters. They are working on that.
There is a question from Dr. Bowen. How often do you encounter visual problems in a long term after placement of a flow diverter stent for in ophthalmic artery, covering ophthalmic artery?
Well, you know, the most favorite segment that we have been treating the supraclavian segment, and they are the ophthalmic one. We have been using a lot of devices there. I must tell you that we had very few problems with the ophthalmic artery, but as you know, there is a very nice flowing coming from the external artery. We still using our protocol first the external injection, just make sure that we have a nice ophthalmic artery coming from the external circulation. But of course, there is always a concern, you know, and that we always keep our antiplatelet regime in the anterior circulation for 6 months, and this is based because we were very reluctant for ophthalmic and for choroidal, for both of them. But the fact is that we don't have that many complications. Even if we follow the segmental, you know, we try to follow those patients, not ourselves, but neurologists or neuro-ophthalmology. We're working with neuro-ophthalmology, so they are very prone to follow those patients with campemetry or with all the studies from the ophthalmologic point of view. But you know, and also remember that you have a very the bend there is very acute, so you must pay attention that your device is very well opposite there, because if you don't have a very good opposition there, you will have a leak, and you will have a ophthalmic artery open, but the aneurysm will still open there because you have again flow modulation in that segment. So first, make sure that the aneurysm is well conformed around the artery. Sometimes you have to massage there, or you have to. There are people that are still doing angioplasty with every single device. We are not that fanatic. We try to use more the wire, and we do always do combine. I mean, the answer there is the combine. You have to have the combine. The combine will show you the real thing, not the fluoroscopy. The fluoroscopy can show you sometimes partial truth, but the combine will give you a truth. You will see all around. You have all obliques. You have several ways. In case that you have depths, please do angioplasty, because if you have an endoleak, you will have a problem.
How often do you have you used the balloon for do angioplasty?
At the beginning, we were using probably 1/3. Now less and less. You know, with those new devices, really, you have a very nice conformability. But probably at the beginning was a little bit more. Was 40%. Now with the wire, probably it's around 15-20%.
Okay, we have a question from Makoto. Hello, Makoto. Is now 10 years passed after releasing stent. When do you start believing in flow diversion? This is the question of Makoto. Is when do you start believing in flow diversion stent?
Well, I always was really a believer. I was not a believer in flow diverter. As Makoto knows, I was a believer to reconstruct the artery. You know, I am neurosurgeon, so to convince me that the device is very good one, you have to you have to have medicine based on really a nice trial, or I have to believe on that. I really believe in that because at the beginning we saw that the coil was no solution for everything. And a lot of people they still maybe thinking that the coils are the solution for everything. The coils was a fantastic step. Was, by the way, was 30 years ago that Guglielmi started with the first implantation of the first JDC. So that was a great step, but the flow diverter was a giant step because comes with the concept that I learned also from Makoto, that we can reconstruct the artery. You know, that is another thing that opened my mind completely because also you don't need to go inside the aneurysm. But Makoto knows because we had a lot of interchange discussion at that time with Daniel in Geneva. It was a fantastic time. I always remember. By the way, best regards to Makoto and our Japanese colleagues. We learn a lot from them. We learn a lot from those, also from that kind of meeting. I think are very productive because there is a lot of interdisciplinary exchange of experience at the very end that counts. We still have a look and have better, I don't say devices, better treatment for our patients.
There is a question from Juan Sebral. Can you comment on patient selection for flow diverter treatment?
Well, as I pointed 2 days before during the course, I think this is one of the remaining problems. We have two problems here: to select a device and which device are we going to use, and also regarding the diameter, regarding the length. So there are several variables that we have to choose. I hope in the near future you guys give us a lot some input. Maybe this device will be better than other ones, but because we can select based on CFD or based on another the wall stress. Today, maybe there is still some for the clinicians for the in neuro intervention, as I will say. We're still waiting for some magic thing that somebody told me, okay, this is the indication for that aneurysm, or this is the indication for another one. I think we are still don't understand. We are still missing some biological things regarding the disease, the inflammation, the completely to see the wall. I think in that regards, probably the answer, Juan, will come from also from intravascular image. I think the intravascular image will give us a lot of information that we really miss. As you know, the view that we have from the wall today is a partial image. We don't really see the wall. We don't see really the position of our device against the wall. Probably we don't see the thrombus even because we think there is no thrombus. But Matt Gunis have been showing nicely that you don't see the thrombus in angiography. But if you have an intravascular device, you will see some thrombus there, and you will see the adherence of the device against the wall. So that interface between the blood, the aneurysm, the device, and the inner lumen of the artery is something that we really miss today, and we need more information for that. But we are looking forward to get more information from you guys and for Juan on all other guys. Really, I think we have a lot of experience. We have more experience than answer today, probably. You know, the neurointerventional community embrace the treatment, the idea, and we have using it extensively around the world. I spoke with the Medtronic, and there are almost 100,000 devices that they already use around the world. So that's a big number. Only Medtronic, and you can multiply that for Fred Jr., for all Surpass or Phenox or Balt. So there are a lot of, but I think we have been using the device, but we don't have the clear understanding of the problem yet. It's like and somehow like a COVID problem, no? We learned that we have the answer, and today or for tomorrow, this is not the answer. There's something new coming in. So I think we have to. That's why I think those symposiums, those meetings are relevant and are very interesting, at least for me, because I always learn.
Well, thank you, Pedro, for your presentation of the SEMQ.
Pedro, maybe I have a question. As you've mentioned, those meetings are really good for exchange, and you have a lot of experience, and we can really learn a lot from you. And what would you ask from us, from the CFD community? What could be the next major step to help you in the understanding or support you in the understanding of treatment? What would be a key parameter? What would you ask from the CFD community?
Well, we were discussing that issue with Juan several times. You know, in Argentina, we call that take a coffee. You know, every time when you call somebody to take a coffee, you have a problem and you need confidence on that. So we have been having tons of coffee try to answer that question, but we need some proof of the thing. We need some clinical proof to the hypothesis that we already have. We need to prove the hypothesis of inflammation somehow. We need to prove the wall shear. You know, every time when I go to a meeting, people start to ask me the same question. Oh, what happened finally? It's a low shear stress. It's a high shear stress. Finally, what happened? You know, I am sure that question comes to you also several times. People don't understand that each of us are different, and each of aneurysms are different, and we have so many variables. You know, so it will be not one weapon for everything. And I think today we are in that setting. We have to maybe to confine, have less variables, and try to come up with something that really, as you said, will help us, a clinician, to make a decision or to have some indication. Let's say, in this aneurysm, with that kind of flow enhancement of the wall, you must do this or you must do that. That will be fantastic. But, you know, this is something miracle. I don't believe in miracles. I believe in science. So we are in a good way. Of course, we always want more, and we will want to have things faster. But this is the way. We discover things, we learn, and we get back with new things. So regarding your question, I think it's a very proper question. We are asking that question ourselves. I will try to answer to that question to every single meeting to the people. But what is the answer? The answer is that comes together and work together. Define 5-6 parameters and work on that. I try to maybe to do some kind of working or several working groups. That one we will work on wall shear stress. That will work on CFD inside the aneurysm. That one will work in the wall. Maybe we have to really define several groups and get the conclusion next year for every single group. Otherwise, it will be difficult to get answers.
Thank you, Pedro. Thank you for sharing your wonderful experience.
Thank you, guys. It has been really a pleasure. Don't remember, today is a World Stroke Day. So let's do something for that. Let's do something for stroke, to aware people that the stroke is out and is taking a lot of lives. You know, we pay attention today a lot of COVID, In Argentina, 30,000 people already died by COVID. But per year in Argentina, more people are dying for a stroke. And there was not that big revolution. We were not in the news every single day with the strokes. So we learned that we have an opportunity. We have to teach the people about our problems. I thank you again for the opportunity to stay with you guys.
Thank you, Pedro, for your impressive presentation. I think your concepts are very clear, and yes, we have to do today something from the stroke, from the accident. Today is the day of the stroke, so we will work on that. I appreciate very much your presentation, and all of you. I think for today was a very good day of the meeting. So we will see you tomorrow in the last day of ICS, maybe remembering Galapagos now. Have a good day for everybody. Saludos para todos. Gracias.
Bye, thank you. Chao, gracias.
Chao. Bye.
Thank you for the organization. Stay safe.
Yes,
Bye-bye.
thank you. Bye-bye. Thanks, bye-bye. Thank you so much.
Bye.
Gracias, Alberto. Buen día.